A very good afternoon, everyone. Today's topic for webinar will be metabolic liver disease. Uh, Before I start the session, I request you to kindly unmute your audios and videos. And the queries, if you have, I request you to type in the chat box so that that can be discussed at the end. This will be for next 30 to 35 minute session. I'll try to make it very simple and brief. Metabolic liver disease. So the metabolic liver disease in children is used for inborn errors of metabolism that involve liver and present either as hepatomegaly and or abnormal liver function test. Basically, what does this convey? This is nothing but a group of inborn errors of metabolism which involve the liver, and they manifest either as organomegaly, either the hepatomegaly or the splenomegaly, or this may produce a disturbance in the liver function that is manifested by elevated serum transaminases, prolonged prothrombin time, low albumin, etc. Now, as you all know, the food what we eat, it gets converted into the simpler substances like glucose, amino acids, and fatty acids, and then they are absorbed. And finally, after absorption, these substances they are broken into further smaller molecules by the series of biochemical reactions that occur, and then it is converted into ATP, and they are utilized by the cells. And so the liver is the biggest chemical factory where there is a lot of anabolic reactions as well as the catabolic reactions that do take place. And so any inborn error of metabolism, it predominantly involves the liver. And what is the disease burden? Why we should know about a metabolic liver disease? Metabolic liver disease, it accounts for about 13 to 43% of acute liver failure in young children. So the predominant presentation in younger ones will be the acute liver failure, and 5 to 20% of this presents either in the form of a chronic liver disease or a cirrhosis with or without portal hypertension, or it can even present as a liver cell failure in older children respectively. And what is the pathogenesis that it takes place in the liver? As you know, any inborn error of metabolism, the substance A should be converted into substance B. This needs a particular enzyme. Once this enzyme is deficient or absent, what happens? The substance A is not getting converted into substance B. So there is lot of accumulation of the substance A, and then second thing is it gets diverted into the other pathways, and that results in the accumulation of the toxic substances. So basically this results in either an acute hepatocellular necrosis or it can result in a cholestasis. So these two are the predominant things that happen in the liver, and the manifestations of this will be in the form of either an hepatomegaly. So this is either in the form of a hepatomegaly, or it could be a presenting as a cholestatic jaundice, or it could be presenting as an acute liver cell failure, or it could be presenting as either a chronic liver disease with or without cirrhosis, with or without portal hypertension, etc. And in the given scenario, suppose a child comes to us. So when we should suspect a metabolic liver disease? Do all children with jaundice results do have a metabolic liver disease? The answer is no, right? So when to suspect a metabolic liver disease in a given setting? So first thing, when there is a parental consanguinity. Two, when there is an unexplained sibling death, like a previous child died of a liver disease, or somebody in the family, the close relative to this index case, having died due to some unknown cause, or they died because of acute liver failure where the cause is not established, or when there is a definitive family history of any inborn errors of metabolism, we should suspect a metabolic liver disease. A child who presents with recurrent episodes of vomiting, failure to thrive, and diarrhea. Remember, these may be the sole manifestations of an organic acidemia and even a metabolic liver disease. Or when the child has got seizures, encephalopathy due to unknown etiology, developmental delay, tone abnormalities either in the form of a hypertonia or hypotonia, yes, we have to suspect a metabolic liver disease. Then a child with a hepatomegaly, jaundice, splenomegaly, acute failure, acute liver cell failure, when there is a coagulation abnormalities like prolonged PT, APTT, etc., and when there is a facial dysmorphism. So these are all the parameters that one should make that should make one suspect a metabolic liver disease in the given case. Yes, so once we are thinking in terms of a metabolic liver disease in a given case, now what are all the histories without forgetting that one should ask? We should always ask for any history of fatty liver in the mother, right, during especially during the pregnancy, or when there is a severe eclampsia, pre-eclampsia, which is associated with maternal hemolysis, elevated liver enzymes, low platelets. I think these two have got a strong association for developing into a long chain acyl-CoA dehydrate deficiency, which is one of the fatty acid oxidation disorder. Suppose a baby presents with a hydrops fetalis, a non-immune hydrops fetalis, what storage disorders that one should think? Either we should think in terms of a Gaucher, we should think in terms of a Niemann-Pick, Barth syndrome, GM1 gangliosidosis. These are all the conditions which are associated with the non-immune hydrops fetalis. And suppose with regards to the dietary history, when there is a development of symptoms, especially after the ingestion of fructose rich foods, say such as honey, fruit juices, etc., that one should make think in terms of a hereditary fructose intolerance, so disorder of the fructose metabolism. Suppose if the child has got any aversion to protein rich foods, for example eggs or meat, then that should make him think in terms of a underlying urea cycle disorder. When there is a craving for protein rich foods where the child asks predominantly only for a meat based diet and aversion to carbohydrates, that may point towards the citrate deficiency. So these are all the special history what we should ask, especially when we are dealing with a child with the underlying metabolic liver disease. So from into that is symptoms appearing after ingestion of fructose rich foods, or symptoms appearing especially to the protein rich foods, or symptoms where one has got a crave towards protein rich foods and aversion towards carbohydrates. So these are all some of the clues that will give in the history itself to make in terms of a metabolic liver disease. Now, so once we know the history, what are the things? Now, what are the things, metabolic disorders that can present as a liver disease? So when we take into a carbohydrate metabolism, things like galactosemia, glycogen storage disorders, hereditary fructose intolerance, and rarely gluconeogenesis defects can present as a metabolic liver disease. With regards to the protein and the amino acid metabolism, think in terms of a tyrosinemia or alpha-1 antitrypsin deficiency. Tyrosinemia type 1, especially they may present in the newborn period, the later half of the newborn period as an acute liver cell failure. Then suppose some child has got a organomegaly. Think in terms of a lipid storage disorders, which may be a Gaucher, Niemann-Pick, Tay-Sachs, Sandhoff's disease, etc. And ICL disease when we are suspecting a disorder of the mucolipids. And mucopolysaccharidosis can present as an isolated organomegaly. And when we are thinking in terms of a mineral metabolism, think in terms of a Wilson disease, which is due to the copper disturbances in the copper metabolism, or neonatal hemochromatosis that can occur because of the disturbances in the iron metabolism. With the bile pigment disorders, think in terms of Crigler-Najjar syndrome, either the type 1 and the type 2, Gilbert syndrome and the Dubin-Johnson syndrome, and bile acid synthesis defects and PFIC, progressive familial intrahepatic cholestasis, can present as metabolic liver disease, either in the form of a cholestasis, or sometimes they can present in terms of a acute liver failure or a chronic liver disease. Miscellaneous disorders like cystic fibrosis, and these disorders, especially the urea cycle disorders, fatty acid oxidation disorders, and organic acidemias, they involve the liver, that may result in elevation of the serum transaminases, and then they can present as a metabolic liver disease. So starting from anything which occurs right from carbohydrate till the bile acid and the bile pigment can cause a metabolic liver disease. Yes, so we have suspected a child has come, we have suspected, yes, this is a child with an underlying metabolic disorder, and we know that these are all the various conditions that can result in a metabolic disorder. Now, what are the investigations that one should ask? First thing involves the basic investigations, which includes the liver function test. One should look for presence of jaundice, whether it is a conjugated or an unconjugated hyperbilirubinemia. Look for the presence of serum transaminases, SGOT and SGPT, which may be elevated more than 2 times the upper limit of normal. Look for the presence of hypoalbuminemia, indicating the chronic liver disease. Look for the presence of GGTP. GGTP is, most of the small laboratories, they don't include the GGTP levels as a part of the liver function test. In fact, the GGTP plays a very important role, and it gives a lot of clue, especially when we are dealing with the cholestatic disorder. For example, the normal or a low GGTP level, which may point towards a diagnosis of a PFIC type 1 or type 2, which is a progressive familial intrahepatic cholestasis type 1 or a type 2, and the high GGTP levels that may give a clue to the diagnosis of a progressive familial intrahepatic cholestasis type 3. So this itself helps us to narrow down our diagnosis to a larger extent. Similarly, a low GGTP may be found in bile acid synthesis defects, etc. Uric acid. High levels of serum uric acid, it is seen in conditions like Lesch-Nyhan syndrome. And remember the low uric acid levels. All of us know very well about the high uric acid levels. Remember the low uric acid levels, which may be seen either in the form of either in molybdenum cofactor deficiency or xanthin hypoxanthin disorders. Next is going to be the serum ceruloplasmin. All of us know, yeah, the low levels of serum ceruloplasmin is a marker for Wilson disease. Then the bile acids. Serum bile acids are high in progressive familial intrahepatic cholestasis. Serum iron and ferritin levels, especially when we are thinking in terms of a newborn presenting with a big liver and a big spleen, right? When we do the serum iron, the ferritin levels which are very high, then that may point towards the diagnosis of a neonatal hemochromatosis. Lipid profile, abnormal lipid profile, especially elevated serum triglyceride levels may point towards the glycogen storage disorders. Elevated cholesterol levels may point towards the diagnosis of a familial hypercholesterolemias. CPK levels are increased in myopathies and mitochondrial disorders, especially mitochondrial disorders where we may expect elevated CPK levels, elevated serum transaminase levels, and elevated serum lactate levels. So the basic investigations helps us to narrow down to some extent what is the type of metabolic liver disease that we are dealing with. And then the next level of the next panel in the basic investigations is going to be the alpha fetoprotein levels. This is not as routinely, but however, a high alpha fetoprotein in the absence of any liver malignancy, think in terms of a tyrosinemia. The urine gives a clue to a lot of investigations. For example, ketonuria may suggest ketonuria without dehydration may suggest towards the diagnosis of organic acidemia. No ketones in the urine may point towards the diagnosis of a fatty acid oxidation disorder. And non-glucose reducing substance. These disorders, especially the newborns where they present with the liver hepatomegaly, seizures, and cataract, especially soon after introducing a milk-based feeds, galactosemia, right? And the non-reducing substance may also be seen in case of fructosemia. Imaging. We order for an X-ray abdomen. When there is an adrenal calcification, yes, it points towards the diagnosis of a Wolman disease. Similarly, epiphyseal stippling, it may be seen in case of a Zellweger syndrome. Ultrasound abdomen, yes, basically to see what is the consistency of the liver, or whether it is a coarse parenchymal echo texture or a homogeneous echo texture, that may tell us a clue that about whether the liver has gone in for a cirrhosis or it's only a state of chronic liver disease. Right? Ascites and dilated portal vein or collaterals which may point towards the diagnosis of a cirrhosis. Similarly, bone marrow examination. A child who presents with a developmental delay has got a big liver and the spleen and presence of some ocular findings, do a bone marrow. Presence of certain cells in the bone marrow. Example, the Gaucher cell may point towards the diagnosis of a Gaucher disease. Cells with the foamy cytoplasm and the nucleus pushed to the periphery may point towards the diagnosis of a Niemann-Pick disease. Liver biopsy reserved in certain cases. Still, it may give a clue to the diagnosis of a glycogen storage disorder where we see a big hepatocytes filled with the glycogen, right? And Byler's bile, especially in electron microscopy, may point towards the diagnosis of a progressive familial intrahepatic cholestasis. So the basic investigations which can be done in most of the settings still helps us to narrow down our group of metabolic liver diseases are includes liver function test, the urine, and then the bile acids, iron, lipid profile, etc. Next, after finishing the basic liver test, what about the next level? So we are talking only about the metabolic liver causes. So what are the basic metabolic investigations that one should do? Remember the easy mnemonic is GALAC, right? So G stands for glucose, A stands for ammonia, L stands for lactate, A stands for the acid base, that is the pH, and K. So the glucose, normal glucose and the hypoglycemia. Hypoglycemia points towards most of the metabolic conditions like a glycogen storage disorder. It may be seen in fatty acid synthesis, fatty acid oxidation disorders. Ammonia. High levels of ammonia are usually seen in urea cycle disorders, organic acidemias, and to some extent it is the fatty acid oxidation disorder. And remember, ammonia levels may also be elevated in acute liver cell failure. Next comes the lactate. Elevated lactate levels. Normal lactate is up to 2.5 micromoles per liter. Any elevate up to 4, it may be seen in conditions like poor perfusion states, shock, sepsis, etc. And any lactate level more than 4 always points towards some form of a inborn error of metabolism. A very, very high lactate level that may point towards mitochondrial disorders, disorders in pyruvate metabolism, and the electron transport chain defects. Next comes the acid base disturbance, that is the anion gap. So the normal anion gap is about 12 to 16, and any high elevated anion gap with acidosis, it may points towards organic acidemias, fatty acid oxidation disorders. And K, ketones in the urine. So ketonuria may point towards organic acidemias, and hypoglycemia without ketones in the urine may point towards the diagnosis of fatty acid oxidation disorders. So this 5 tests can be done in any small hospitals and any small laboratories. With this, again, helps you to narrow down the metabolic liver disease to a lot extent. The other specialized investigations, what we are asking is the amino acids. Plasma amino acids, yes, a specific amino acid elevation may point towards the diagnosis of certain conditions, right? And acyl carnitine assay helps to narrow down your diagnosis of organic acidemias and the fatty acid oxidation disorders. Urine organic acids. High urine organic acid levels may point towards the diagnosis of underlying specific type of organic acidemias. Urine succinyl acetone. Urine succinyl acetone is very high, that points towards the diagnosis of a tyrosinemia. Urine orotic acid. This is very, very important in the context when we are dealing with the urea cycle disorder. Remember, this urine orotic acid is not a part of urine organic acid, that has to be specifically asked for, right? And this is high in case of urea cycle disorders. Specific enzyme assays like glucocerebrosidase, sphingomyelinase, etc. helps to point towards the diagnosis of a lipid storage disorders like Gaucher, Niemann-Pick, Tay-Sachs, etc. Molecular gene testing plays a pivotal role in establishing the diagnosis as well as offering the genetic counseling for the family, right? And so still so far what we have seen is what are the incidents and the prevalence of the metabolic liver disease, to what are all the inborn errors of metabolism that can manifest as a metabolic liver disease. 3, when one should suspect a metabolic liver disease in a given child. 4, once we are suspecting, what are all the specific history and the specific examination what we have to look for. 5, what are the investigations that one should order when we are dealing a child with metabolic liver disease. Now, going through a few case scenarios. Now, this is the 4-month-old male infant who presents with seizures noted by parents at 5 a.m. in the morning. So it's the early morning hypoglycemia, and child has grown big, so the frequency of feeding has come down. When the child is brought to the casualty, the child is seizing and he has got moderate hepatomegaly. So the baseline investigations are as follows. This child has got low glucose levels, urine for ketones is negative, LFT, RFT, and CBC are essentially normal. Sorry. Look at the lactate levels. Lactate levels are very high, uric acid level is high, and ammonia level is normal. So this is a child who presents with hypoglycemia, has a hepatomegaly, has elevated lactate levels, has elevated uric acid levels. So the probable diagnosis is a glycogen storage disorder, right? So knowing this, how do you proceed further? Yes, we have to ask for serum triglyceride levels. Again, elevated serum triglyceride levels points towards the diagnosis of a GSD type 1. And how do we proceed further? Yes, a liver biopsy can be done to show the presence of hepatocytes which are distended with glycogen. So this slide shows you these are all the hepatocytes, and these are all the white things are the glycogen, and the nucleus is pushed to the periphery, and this is a pase diastase positive, and so that confirms your diagnosis of a GSD type 1. So how do we proceed further? Again, we do the gene mutation testing to find out what type of mutation it is. And how do we basically treat this infant? Basically explain to the parents, yes, this child has got a glycogen storage disorder. The main thing is to avoid hypoglycemia, so frequent feeding should be given. And next most important thing which forms the cornerstone for therapy in children with glycogen storage disorder is uncooked cornstarch. So the dose is below 2 years, it is 1.6 grams per kilo, and they have to mix cornstarch in water. So basically the ratio is starch is to water ratio is 1:2. So 1 teaspoon of starch with, cornstarch with 2 teaspoons of water. And please repeatedly tell the moms that they have to give only uncooked starch. Most of the moms, they just boil, make it as a kanji, and then they give, where all the glucose polymers are going to be destroyed, and it is going to be a useless therapy. And second thing is, they should avoid fructose, lactose, and sorbitol, right? So these are all the small things that we should tell the family about we are encountering a child with glycogen storage disorder. So the next thing is, this is a 5-year-old girl who presents with short stature, protuberant abdomen, and frequent falls during walking. On examination, she is very short, right, and has moderate hepatosplenomegaly, and on made to stand from sitting position, she has got a proximal muscle weakness. So if you look at her glucose levels, it is 60 milligram per deciliter. The renal function test and blood counts are normal. LFT shows there is marked elevation of the serum transaminases, and CPK level is also high. So short stature, hepatosplenomegaly, elevated serum transaminases, and CPK. So most important thing will be again a glycogen storage disorder. Since this has got involved a liver and the muscle, so probably this may fit into the diagnosis of a glycogen storage disorder type 3. So the pointers towards the diagnosis are a hepatosplenomegaly, myopathy, elevated serum CPK, and the serum transaminases. So coming to the salient features of glycogen storage disorders, so GSDs are basically divided into two. One is the hepatic glycogenesis, another is the muscle glycogenesis. Hepatic glycogenesis are predominantly 1, 3, 6, and 4, 6, and 9, and the muscle glycogenesis are predominantly type 2, type 5, and type 7. Okay, so there are various mnemonics to remember this GSDs, and one of the easiest mnemonic is, all of us have got a great this thing to go to Switzerland for a holiday, right? Especially the Mount Altus and the Mount Titlis, which makes the people to come and see every time. So it's a very pleasant, cool Altus makes her to test. So very stands for a what? Type 1 GSD, which is a Von Jerky disease. P stands for the Pompous. C stands for the Chorus. A stands for the Andersons. McArdle's disease, Hertz disease, and the Taurus disease. So this is the mnemonic to remember the various names of this GSD. And this table helps to differentiate what are all the cardinal classical features and the biochemical features and the treatment of various types of glycogen storage disease. So the main focus is type 1. So these are all the characteristic biochemical features: hypoglycemia, lactic acidosis, hyperuricemia, hypertriglyceridemia, and the treatment is basically the uncooked cornstarch, right? And type 1b especially will have a recurrent infections, and this is the type 3. So again, hypoglycemia, hypertriglyceridemia with elevated serum transaminases, elevated CPK, and here also the cornstarch forms the main thing for the treatment. So next is this is a 7-month-old female infant. She is first born to second degree consanguineous parents. She presented with fever, cough, and cold for 4 days. Right? On examination, she was febrile, had pallor, hepatosplenomegaly, and hypotonia with grade 2 develop deep tendon reflexes. So this mom basically presented for only the respiratory ailment. On seeing the baby, further probing into the history, there was a developmental delay. This child has not even had a head control, and there was a mother felt the child was floppy. And so the clinical examination wise, she has got a moderate to marked hepatosplenomegaly, and we thought so developmental delay with hepatosplenomegaly. Then we proceed with the ocular examination. Ocular examination revealed a cherry red spot. So this further narrowed down to the diagnosis: a child who presents with hepatosplenomegaly, developmental delay, having a cherry red spot. It is only either a Niemann-Pick disease, Tay-Sachs disease, Sandhoff disease, and the GM1 gangliosidosis. So these were the four differential diagnoses what we kept in our mind, and the bone marrow examination revealed a Niemann pixel, which is nothing but a large cell which has got a foamy cytoplasm and the nucleus almost pushed to the periphery. So we did the molecular gene testing, which confirmed it is a Niemann-Pick disease, and we offered only a supportive treatment, and the child finally succumbed. So this tells us, yes, this is the only the where the presentation is only an organomegaly, right? So organomegaly in the big background of a developmental delay with cherry red spot, again storage disorders may come top into the differential diagnosis. Again, this is a 4-month-old baby who was instantly found to have a hepatosplenomegaly during routine immunization visit to the clinic. This baby has been brought for immunization purpose. And on examination, the pediatrician picked up the hepatosplenomegaly. An ultrasound abdomen done as a part of workup showed again an organomegaly with adrenal calcification. And this is the X-ray which showed there is an adrenal calcification. So the diagnosis is, yes, it is a Wallman disease. Hepatosplenomegaly with adrenal calcification most pointedly towards the diagnosis of a Wallman disease. So here the diagnosis comes from the radiology department. Then we did the molecular gene testing which showed presence of Wallman disease in the child. So with regards to the treatment, yes, there are a lot of disorders which can present with either hepatomegaly, splenomegaly or hepatosplenomegaly. Those disorders which present as splenohepatomegaly is gaseous. Gaseous predominantly presents as a splenomegaly. Niemann-Pick disease can present as a splenohepatomegaly, right? And there are various enzymes that are available for the treatment of lysosomal storage disorders, right? And these are all pretty expensive. Next comes a 53-day-old female infant who presented with lethargy and poor feeding for 2 days duration. There was no fever, vomiting, or reduced urine output. On examination, she was afebrile, drowsy, and this baby had hypotonia. Cardiopulmonary examination was normal, and abdomen exam revealed a hepatomegaly. Again, so lethargy, poor feeding, and hepatomegaly, right? So these are the points towards thinking in terms of a metabolic liver disease in this baby. So the investigations reveal normal blood counts. Basically, sepsis has been ruled out, negative CRP, electrolytes were normal, and this shows the elevated serum transaminases. So here there is a probable metabolic disorder which presents with an organomegaly with elevated serum transaminases. Here the presentation is not in the form of a acute liver failure or a chronic liver disease or a cirrhosis. And ABG showed metabolic acidosis with increased lactate levels. The lactate level is 9.9 and normal lactate pyruvate ratio. So with this, the probable differential diagnosis that was considered as a congenital lactic acidosis, or it could be a disorders in the pyruvate metabolism. As I have said earlier, a very, very high lactate levels, which is out of proportion. Always one should think in terms of disorders in the pyruvate metabolism, disorders of electron transport chain, or a mitochondrial disorders. So we thought of pyruvate dehydrate deficiency, and the molecular gene testing for this baby confirmed a missense mutation in exon 7 of PDHA1 gene, again confirming the pyruvate dehydrate deficiency. So this baby was treated with bicarbonate for acidosis. In view of very high lactate levels, we did the peritoneal dialysis. It was the timing of the peritoneal dialysis that has saved this baby. And this baby at now 1.5 years of follow-up, she is developmentally normal and is doing very fine. Now, the moving on to the next case. So this is a 10-year-old boy who was second born of first degree consanguineous parents. He was brought with history of jaundice for 8 months and abdomen distension noted for 1 month. There was no history of any GI bleed, altered sensorium, dystonia, dysarthria, drooling of saliva or drug intake. And there was a poor scholastic performance, a recent change in his handwriting, and there was history of eldership death due to similar illness. So now, so far we have seen infants and small children, liver disease. This is a bigger boy who was brought with the recent onset of jaundice. Family history of SIP death is there. Recently noted a deterioration in the school performance. Okay, so the diagnostic possibility is probably a Wilson. So on examination, he was having icterus with pedal edema, bilateral KF fingers present. Abdomen shows moderate firm hepatomegaly, splenomegaly, and free fluid, and other system examinations are normal. So these were the investigations. Investigations revealed a low hemoglobin, and almost a pancytopenia type of picture, and a conjugated hyperbilirubinemia with elevation of serum transaminases, hypoalbuminemia, prolonged prothrombin time, and low serum ceruloplasmin. Again, so KF ring is there, low serum ceruloplasmin is there. So this fits into a diagnosis of a Wilson disease. And endoscopy done showed a presence of varices again. So still cirrhosis with a portal hypertension. So with regards to the manifestations of Wilson disease can be either asymptomatic, yes, they can just present only with elevated serum transaminases, 3. In the routine OP, it may be picked up only by the instantly, that is hepatosplenomegaly. 4. It can present either as an acute hepatitis, chronic hepatitis, fulminant hepatic failure, chronic liver disease, cirrhosis, or end-stage liver disease. So, Wilson can present from anything right from asymptomatic till the cirrhosis with the portal hypertension, and it can present into any department. For example, it can present to the hematology department with only a pancytopenia. It can present to the psychiatric department with all the neuropsychiatric manifestations. It can present to the gastroenterology department with the jaundice and organomegaly. So it can present as any to any department. And the diagnosis is yes, suspicion. And when we do the slit lamp, we look for the presence of KF ring, low serum ceruloplasmin, increased 24-hour urine copper following the deep penicillin challenge test, liver biopsy, and where we document for the hepatocyte degeneration and dry copper content of the liver, which may be increased, right? And so this is basically an abnormal accumulation of copper in various tissues, that is the liver, brain, kidney, and the red blood cells. It can present as an asymptomatic or only a hepatic manifestations or neurological manifestations or combined hepatology plus neurological manifestations. And when we suspect Wilson's disease, when we diagnose Wilson's disease, we have to do this contact screening of all the asymptomatic siblings. And the next case is, this is a 14-year-old boy. He was apparently well till last year, and for the last 1 year he has been itching, right? And he has the itching was so marked that even his hands and palms have become so thick, and there was no abdomen distension. Parents have not appreciated any jaundice, and they gave the boy himself gave the history that he is occasionally passing the pale stools or the white stools. So on examination, we noted a faint dick press. Abdomen examination revealed only a mild hepatomegaly. There was no splenomegaly, and there was no ascites. So we did a liver function test. He has been running from pillar to post, and he has been received all sort of antihistamines and the antipruritic agents. And when we did the liver function test, his bilirubin was high, 6.5 with a conjugated hyperbilirubinemia, and there was increase in the serum transaminases. As I have said earlier, the GGT was low and the serum bile acids were high with normal albumin levels, normal coagulation profile, and ultrasound abdomen showing a hepatomegaly. So this is a boy, a very big boy. There was no family history. Only manifestation is pruritus. Clinically, he had mild jaundice and a hepatomegaly with elevated liver enzymes, jaundice, and low GGT levels. So the probable working diagnosis at this stage could be either the progressive familial intrahepatic cholestasis 1 or 2 or the bile acid synthesis defects. So we did the genetic mutation testing, which showed mutation in the ATP8 B1. Uh, confirming the diagnosis of a progressive familial intrahepatic cholestasis type 1. And this boy has been treated with the choleretics, and genetic counseling has been given to the family, and the stress for the long-term follow-up has been advised to the family. So to conclude, yes, metabolic liver diseases are common. It is not rare as it was thought of. Two, metabolic liver diseases can present either as only the isolated hepatomegaly or hepatosplenomegaly, or it can present as a liver cell failure, or it can present as a cholestatic jaundice, or it can present as a chronic liver disease, cirrhosis with or without portal hypertension. So there is varying modes of presentation. 3. It can present at any age, right from the fetus as a non-immune hydrops fetalis. It can present in the neonate, right? It can present in infancy, it can present in older children, and even sometimes can present in adults. 4. A high index of suspicion is always necessary, and we should always ask for specific history, complete physical examination, including the general examination. And next thing is the investigation should be tailored to depending upon the each and the individual etiology. With regards to the treatment, yes, there is definitely treatment available for few disorders, like avoiding a galactose formula for a child with the galactosemia, offering a liver transplant for an NTBC for tyrosinemia, of ordering cornstarch for glycogen storage disorders, and in few disorders the treatment is only supportive, as in case of Niemann-Pick disease and Wallman disease, or few lysosomal storage disorders where enzyme replacement therapy is very expensive and it is not available in most of the places, right? And the treatment doesn't stop with the child. We have to do the gene testing and we have to offer the genetic counseling to the affected families. Liver transplant and hepatocyte transplant has got a significant role in dealing with the child with metabolic liver diseases. Thank you.